There we go. And I want to welcome you to our October Wellness Nurse call. We're going to talk about two things today. We're going to talk about the SASH assessment. There are some updates to the assessment, which I'm sure you've been seeing, and if you attended training, you're aware of some of those. There are a lot of questions that came from the field, so the point of today is to ask those questions and get them answered, as well as my sharing what I've been hearing from the field as well with you. And then I have a short update on brain health. It's a recent publication that came out this month. Of course, it has something to do with hypertension because that's my other hat that I wear. So this, instead of giving you a picture of me today, this is my office mate, Bosco. He's a black lab rescue. He, poor Bosco's he's on hospice, unfortunately. He's got sarcoma in both his ankles, or not ankles, elbows, front elbows. So he looks a little dopey, but he's right there now, too. I'm just looking over him. He's in that same spot every day. You'd think he wouldn't be comfortable. The other person that helped me put this together is Melissa Southwick, and this is her dog, Spot. Spot just joined Melissa's family, but Melissa gave me a picture of him. And what was interesting is Tuesday, Christina Melvin was on the phone call, and she has Spot's sister. So I think we're going to kind of continue this little dog theme into the next months and share some of our animal pictures, because it's just fun. It's fun to see what kinds of dogs people own outside of work, I think. So today we're going to go over the SASH assessment. We'll do an overview. We'll talk about what's new and some FAQs and myths from the fields. Any questions that you have, definitely chime in. I do have the chat up. If you have a question, I'm not as good as monitoring the raising of hands, so using chat is really the best thing for me. And then we'll go through brain health and any questions and answers. And that will probably take up almost the whole rest of the 50 minutes we have. So at the end of today's presentation, I'm hoping that you have achieved two objectives. One is to gain further knowledge of our SASH assessment with specific focus on the new evidence-based screens, and then gain some knowledge on brain health and Life's Simple 7, and consider how to incorporate this information into your practice. So first off, I'm going to show you the tabbed view of the SASH assessment in PHL. And on the bottom right is the picture on the SASH forum of the desk aids. These are those simple aids to teach you how to do like one simple step. So keep your eye on this area. As the team develops more desk aids, they will be published in this same area on the forum. If you need a desk aid, like there's something that comes up and you're like, Christy, this would be a really good idea, you can let me know and we can have the team consider putting that into a desk aid format. And I think as we start using PHL more and more, those requests will come up, and we'll approach them as they do come up. So let's go through some of the aspects of the assessment we've been having questions on today. I'm going to touch on some of the idiosyncrasies of PHL, but if we have deep PHL questions, I want to get those documented and we'll bring those over to the team. This is not, I'm not going to pull up PHL and do a demonstration of it, but we can definitely have that follow-up. And Amy's here too. She might be able to answer a question if it comes up, because I know she's been answering a lot of questions from the field. So this schematic shows you who does what on the SASH assessment. And what you see are the tabs of the clinical visit window. The dark green tab is the visit tab. You know, we have to create a visit, and that visit then activates all the tabs in the visit window. The other yellow tabs, sorry, I'm going back and forth with my colors. Those are the SASH coordinator tabs, and those two tabs that the coordinator is responsible for are the SASH coordinator assessment and the person-centered interview. The second portion that we'll look at here are the blue tabs, and those are the wellness nurse assessment tabs. That is the clinician, that's your primary care, and your specialist. We'll look at that area in a minute of the assessment. The diagnosis, meds, allergies, med review, and meds and med review, as you know, that's on hold right now. The vital signs tab, the ADLs, IADLs, PHQ to PHQ-9, the nutritional assessment, the falls risk assessment, general health assessment, mini-cog, GAD-7, SMSG or audit, and then DAS-10. The areas that are green can be performed by either staff member. So you can use care utilization now. We'll talk about some caveats to that. Transition planning, I'm going to talk about a big caveat to that, that tab. Notes, obviously you and your coordinator shall be using that area. Social connectedness, that's your Lubin social network scale, and the UCLA 3 questions, we'll look at that. Falls history, and then, and actually it should be falls risk assessment, I'm sorry, that can be done by either. And then the Columbia Suicide Severity Rating Scale should be also. The black tabs are going away. That's risk stratification, readmit root cause. I don't even know what SRM is or CG monitor. We're not doing anything with those. And then health literacy. So that's an overview of who does what, and let's start looking at the assessment. The most current copy of the paper assessment is on the SASH form. It is, when you pull up the form, it's right there. You click the button and this is what you get. So double check with what you're using in the field and compare it to this and make sure you have the most current version printed for when you are in the field. And I realize some folks are able to use PHL in the presence of their participant while they're doing an assessment, and some folks are not. They're needing to use a paper assessment, and that's for many reasons. One, it could be just not being comfortable with the flow of PHL yet. I understand that. And secondly, you may not have internet access. Some advice I want to make to you. So have additional paper handy for your own notes. You need paper for the clock drawing for the mini-cog, and I would consider this like almost a parking lot piece of information. There are little note sections on each of the tabs. If you enter information into these areas, it is not easily retrievable. For example, somebody asked me the other day, they had identified cancer as a chronic condition, and they wanted to make more notes on what the cancer was. If you put a note anywhere in that tab, it doesn't show up anywhere. It doesn't even show up on the table where it populates the chronic condition tab. So my advice is gather those bits and pieces of information that you, when you write all over the assessments, and I always made notes in the corner and such, and collate all that at the end, and as a best practice, put all that information into a note. You can title it, all bold, new SASH assessment, SASH reassessment. You can even all bold things like transition of care. Talk with your SASH coordinator, decide what makes sense. I do think these two titles make a lot of sense, so I would start with those. And then if there are other visits that you would like to put in caps, definitely do that. And I've got a comment from Amy that says, Christy, we're updating the paper assessment. Okay, and so if there are any suggestions to make it a little bit more usable, user-friendly, why don't we get those into Melissa Southwick and Amy. You can send them to me as well. I'll send them on to them. But if you do have suggestions on that paper assessment and the flow of it, get that information in. This is the time to do that. Let's move on to immunizations. Now, this area in PHL is not in the clinical tabbed window that we just reviewed. So it is, it's in the visit, the client window, and we've got an enhancement request into PHL to move that at some point in time. I do not have a date. What you can do, this is a picture of the paper assessment, is you can ask your participants if they know when they had their flu shot, pneumonia, Prevnar, shingles. These are things that we track. It is an outcome of SASH, and put the most approximate date that you can. So if they say I had it sometime in October, sometime in September, you can date it the first of the month. And then no med, that was a question by somebody that just, means the participant cannot receive the immunization because they're allergic to it. This is the discussion about clinical utilization tab. In the future, patient ping will populate this tab. So in the meantime, you and your coordinator can document transitions in here. The transitions tab, I've looked at it. I have not come to a determination of what a good workflow would be to use with that tab right now. If you find it useful, great, but right now that tab is not mandatory for you to enter information on. And care utilization, really, that's, like I said, that's just documenting the transition of care. You can document more details about a transition of care in a note. The clinician tab, SASH coordinators can help you fill this out. Typically, they're meeting with the participants first, more often than not, so they would know who, they could have that discussion of who the primary care doctor is. Hold on one second. Sorry about that. And you can come into this tab when you do your assessment and say, you know, I see that Dr. Cornelius is your primary care at Rutland Regional Medical Center. You know, is that true, yes or no? And just confirm that. You can enter specialists here as well. And if you need more space, add an extra piece of paper because there's only a certain amount of space on this form. And if there's any details about the specialists or clinicians, again, put the information into your note. We are not being asked to use the ICD-10s. We will use the non-clinical diagnosis, which is your chronic conditions, and you complete that as usual. There is some questions about effective start date, effective end date, date of onset or exacerbation. If you have this information to enter, you can. It is not mandatory. And the last three questions here, questions this client has about their diagnosis, and those other two, those are not mandatory questions. So do not feel that you need to ask those questions. Again, if you have any additional notes, especially about the chronic conditions, put those in the note section. So the medications tab, that is on hold. Entering medications into PHL is on hold. It is going to change. What it's going to look like, I do not know yet, but I am hearing that the engineers are working on reworking that area of the product. What was missing, just so you're aware, is a subscription service to a medication data dictionary. So that is something that PHL was working on. What you had in there was the listing of medications from when we were on DocSite, so it was not up to date nor complete. So, so right now you're on hold entering that medications data into PHL. However, you're still responsible for performing a complete medication reconciliation, and you can do that on paper. This table that you're seeing here at the top is in the paper assessment, and you can enter the medication compliance information if you find it useful. It's hard to use because in the system it has each compliance entry screen for each medication. So if you had, say, caregiver issues, or client refuses to take, that's a better example. Like say they refuse to take their Lasix, you'd have to write in Lasix there. So again, this is an area that we're evaluating right now for some of its usefulness and how we would use it moving forward. If you remember, I think it's been about a year now, it might have been a year and a half, we did a review of the Mariski scale and we really liked it. Mariski scale is a medication adherence screen, and unfortunately it costs money, so we're not going to use that. It's too expensive. They charge per person per screen used. So we're looking at other medication adherence screens and other ways to document medication compliance, because that is one of our challenges. And I get calls every week about that. And Todd's saying, my dog is playing with his toys. Sorry about the squeaking, and that's okay. Mine was just talking to me behind me, so if you heard him speak, I apologize. Oh, one last thing. I'm going to go back to that slide. We did have in August, we had a review of the medication reconciliation process, and that official protocol is almost ready for your review or for your sign off on it. It is being signed off by administration. And when I say sign off, it will go out to you and you will have to acknowledge that you've received it and read it. But we did a review of it in August. So if you need to go back and look at how to do medication reconciliation, you can look at that webinar. I thought it came out pretty well. Pharmacy information, right now you need to document that on paper. You cannot document it in the application. It does not stick, but document it on paper, and then once we go live with medications, we'll give you further instruction on that as well. Allergies and vital signs. So you can enter allergies as per usual. That's just fine. Document those as you normally would. And then on the vital signs tab now, you have the ability to also enter an orthostatic blood pressure. So if you can get this information, as much of it as you can, during your assessments, blood pressure, hopefully sitting, heart rate, height, weight, BMI will calculate in the system for you. You don't need to know that calculation. Temperature, pain scale. If you can get a hemoglobin A1C, we're actually going to start a pilot regarding diabetes and hemoglobin A1C. So if you can obtain that information, say your patient knows what their hemoglobin A1C is, great, we'll take it. We'll take the information. We do not have a lab feed, but learning more information about A1C is of significant interest, and we are going to be tracking that data for a pilot, not for everybody, but it will actually be a pilot down in Rutland. So going back to orthostatic blood pressures, can anybody tell me, do you know what one of the reasons would be for why you would want to utilize a set of orthostatic blood pressures? And that's a blood pressure lying down, a blood pressure sitting, and a blood pressure standing. Any thoughts on that as to why that might be useful for you in the field? Any suggestions? Anybody want to speak up so I don't have to pick on someone? Oh, there we go. Thank you, Todd. Falls prevention. Did somebody else speak up?
I said dehydration or internal bleeding.
Yeah, I mean, dehydration is a great one, especially in the elderly. Yeah, internal bleeding as well, low volume, right? They've got less volume circulating. So this came up as a piece of feedback from some primary care physicians that if you have somebody that's falling a lot, let's get a set of orthostatic blood pressures. It's not part of our protocol. We haven't gotten there yet, but it's good information to understand. It really gives the physician's office a little bit more information to work with. So yeah, good answers all around. Falls prevention, dehydration, and maybe some bleeding going on, which is decreasing the circulating volume that somebody has with which to work. So I'm going to take just a second here. I've prepared 845 slides for today's meeting, so if you want to survive, you have to ask questions and interrupt me and challenge my opinion. I love Dilbert. Any questions thus far that anybody has before we go further? It's going really well for you. You want to save your questions to the end. All right, I'm going to keep going. If you have more questions, you can chat them in or interrupt me as well. This is a small group. You can interrupt me. ADLs, IADLs, that's pretty self-explanatory, so you'll evaluate that with your participants as well when you're meeting with them. The PHQ-2, when you answer those questions, and if the score is 3 or greater, you'll go to the full PHQ-9. One tidbit, one idiosyncrasy in PHL is that data does not transfer over, so you need to take the answers to those first 2 questions and populate them yourself into the screen on the other tab, and then complete the full screen. If you have any notes, again, I'm going to be a broken record today, put them in the notes section. This is the nutrition assessment screen, and these are questions that you've worked with before. However, there are questions in here that are things that you could work on with your participant. For example, do you sometimes not have enough money to buy the food you need? This could be a parking lot item, and this is something you could help the person with to help them improve their nutritional risk. So it is definitely an observation that you're making, and like I said, something that you could put in the parking lot. Part of when we do our assessment, right, we're identifying gaps. So we'll assess, we'll identify those gaps, and then we need to start putting together a plan to address those gaps, and the plan, of course, with our participants, so it's person-centered. But there are definitely, some of these screens will lead you to some interventions that you and your SASH coordinator can take. Falls risk assessment and the falls history tab. So the falls risk assessment moved over to the steady screen, and I do have an idea for you if you want to take me up on it. That's great. If not, that's fine too. But these questions are great because it says, I have fallen in the past year and why it matters. People who fall once are likely to fall again. So it gives some really good rationale for the participant and some good feedback. And then you can enter your falls history data as well of recent falls. One idea is this screen is available in doctor's offices and is something that primary care providers are encouraging their participants, their patients, to fill out, and then they review during the visit. If this is something that helps you streamline your assessment, one thing for you to consider is print off the brochure. It's right here on the CDC website. You'll have that available. And it is the Stay Independent brochure, and it has the questions. They can go through them themselves, and then you guys can review it at your meeting when you do your nursing assessment. So that might be one little way to speed things up a bit for you. The general health assessment, there's two things I wanted to point out here. The new questions regarding feet, those were requested. We have foot care is a hot topic these days, and how people get foot care or how they don't get foot care. So we decided to do some, add some questions and do some tracking for that. So we can, in the future, be able to pull some reports on these data elements that you enter. The other thing that we heard from the nurses was that there was a question about physical activity. Somehow it left the assessment, so it was asked to be put back. So that question is also in there. The other questions that are in the general health assessment are the pre-screening questions, and I'm going to go through those as well, the pre-screening questions for alcohol, drugs, and suicide. So we'll look at those as well as we go through those screens. This is one of the shared assessments. And we have historically documented the Lubin Social Network Scale, and that talked about connectedness but not isolation. And so we did some research on this issue, and we found that the two screens combined give you a better picture of social isolation, and they allow us to track improvements better than just Lubin Social Network Scale alone. So, so we're asking those questions. We're not, we don't have the report based on this data yet, but we will. It is one of our SASH outcomes that we track and report into the state. Todd has chimed in and said long toenails, ingrown toenails, bunions, etc. can cause elders to be unsteady and fall. Absolutely. So foot care. You learn an awful lot when you look at people's feet. It's really interesting. It opens up a good conversation for sure. The mini cog. Remember I said in the beginning, make sure you have some extra paper with you so that your participant can draw a clock on it. The clock needs to have their name and the date the test was performed, and you need to save that piece of paper in their file year after year. And it is very interesting when you've been with somebody for 3, 4, 5 years in some cases, and you look at clocks over time and the change. So please save your clocks. That's important as well. If you have questions about how to perform the mini-cog, the instructions are in the paper assessment. They're in the PHL system. But if you have questions about how to perform that, you can you can definitely let me know, and we have a training that's now available, courtesy of Dr. Pendlebury. Andy is chiming in saying, correlation seems significant when metoprolol causing low pulse and dizziness causing fall. Good to know. I think that I haven't read too much about that, but I can definitely see it happening for sure, because it's going to block the heart rate down. So I can see that if they have a really high dose of metoprolol. So there you have it. Good point, Andy. Thank you. Another two questions that are in the general health assessment are the GAD-2, and we have the same scenario here. If the total score of the first two questions is 3 or higher, please continue over to the GAD-7. And again, these two questions do not pre-populate the GAD-7, so you need to bring those two answers over and then complete the entire screen. The two pre-screening questions about alcohol, and if the second question, if the answer, well, the first question, if the answer yes, you continue to the second question. How many times in the past year have you had 4 or more drinks in a day? And if the answer is 2 or 3 or more, you continue on to either SMSG or the audit. Is the participant under 60 years of age? Yes, you do the audit. If they are over 60 years of age, no, you do the SMSG. So I did have somebody completing an SMSG on every one of her SASH participants. You do not need to do that. It is if they screen positive based on these two questions, and then age determines which of the screens you will use. Okay. There we go. A new screen that we've added is the DAST-10. And so the question is, how many times in the past year have you used an illegal drug or used a prescribed medication for non-medical reasons? And if the answer is 1 or greater, you continue on to the DAST-10. And the way to go about asking those questions is listed in the DAST-10. If you're concerned about asking these questions, because they are sensitive questions about alcohol and drug use, there is in February of 2017, there's a webinar that we did with Charlie Gurney from Department of Health. It is I would say, like an SBIRT primer on asking these questions, and Charlie gives some really great tips on how to have these conversations with folks using some motivational interviewing skills. And I suggest taking a look at that webinar. The other thing that I want to bring to your attention is we've had a few really tough situations with participants in terms of alcohol and drug use, and Charlie has been willing to consult one-on-one on the phone with the wellness nurse and brainstorm some suggestions and resources with that nurse, and those conversations have gone pretty well. So just know that that is a resource. I can help connect you. He is one of our, he's one of the people I keep in the back of my mind when a nurse is calling me about one of these two issues, because I am not an expert in all of those areas, and that is Charlie's expertise. He really likes it when we call and ask for his expertise in a one-on-one. So I think he enjoys it. The Columbia Suicide Severity Rating Scale will be added to the assessment very soon. You need to complete this one question on every SASH participant. This is another one of the outcomes that we are tracking as part of SASH. You also should have received an email regarding the Columbia Suicide Severity Rating Scale training. If you have Relias, it came through, it'll be available in your Relias account, or if you do not have a Relias account, you should have a link to training. Amy sent that out. I want to say it's been, I think, almost 2 weeks. So please look for that in your email. It takes, I think, about an hour to go through it, but it is an online training that will help you administer the screen should you need to do it. I did have another question from the field about concern about doing the screen. And the one thing that you should understand is this is a national initiative, and this screen is being taught in high schools. That is why coordinators can perform the screen. That is why the nurses can. So it's a team effort in completing the screen should it need to be completed. And if you have questions about this, definitely bring them back to us. Melissa Southwick, she said on the other call, she said this is her passion project. So she really wants to make sure that any questions or concerns in the field are addressed. The other thing that I wanted to bring up is in about April or May, every panel received a yellow folder, and in that folder are resources and tools for suicide prevention. If you haven't seen that folder, please ask. It went to all of the SASH coordinators. Please take a look at what's available in there. There's some really good resources, and we did have, Melissa and I had a conversation with another nurse who was not aware of the yellow folders. They just hadn't made it to her panel. They're for the panel. They're not like per person. So definitely have that conversation with your coordinator. And we have a chime in from Samantha Mitchell. The CSSRS training is very good and gives you examples how to ask and how not to ask questions. So perfect. Thanks, Samantha. It's actually in my training as well, and I haven't completed it yet. So I need to do that so I don't get in trouble either, though. So I'm going to take just a little pause before we discuss brain health, and I'm wondering if anybody has any questions about the assessment, any concerns, anything you want to bring up. Training at retreat says it is important to be more direct. Are you or have you ever been suicidal? That's from Andy Donovan. Okay. Good insight too, Andy. And I'll relay that over to Melissa as well. Any other questions? Concerns? It's going great for you out in the field. You love the assessment. It works perfectly. No problems. All right. I'm gonna take silence as a yes, although I have a feeling that there's some more input that y'all would like to provide. And I think it's important. This is the nursing assessment. It is our assessment. So when Amy Rogers was speaking to the point, or she chimed into the chat that we're looking at evaluating the flow of the assessment. If you have suggestions, please provide that to us. It's good insight. You're out in the field. You're working with the assessment. I have not administered this assessment on a participant. The last one that I did was the red cap one. So your input right now is really crucial. So with that, I'm going to switch gears and we're going to go into brain health. This is a new publication. This came out in October this month. It's a joint statement from the American Heart Association and the American Stroke Association from the Presidential Board regarding brain health. And what I'm going to review with you should sound familiar to much of the work that you do in your practice. We have our very large hypertension management initiative, and Andy, I know you're new, but you will that will be part of what you and I discuss, and there's also a training on it as well. But let's look at this a little bit. The article provides considerable amounts of data, and you'll have it available for you to take a look at as well. But I thought I would just point out some of the interesting facts, and this was really interesting. By 2030, it's estimated that there will be more than 50% probability that women in most international regions will break the 90-year survival barrier, which I thought was amazing. And that includes North America. So the public health challenge is to plan for health and social services, housing, and pensions for the elderly, and to care for those at risk for cognitive impairment and dementia. They do talk a lot about stroke and stroke prevention in this article as well. And at present, there's an estimated 47 million people with dementia worldwide, and they're expecting these numbers floored me, to increase to 75 million in 2030 and 131 million by 2050. Our population's growing, and we're living longer, obviously, so we need to be able to take care of one another. And then I liked this definition from CDC. A healthy brain is one that can perform all the mental processes that encompass cognition, such as the ability to learn and judge, use language, and remember. And the purpose statement of why they put this out was to expand knowledge for defining optimal brain health in adults and suggest ways to maintain it. And they said that this information would kind of be their foundation, their platform for moving forward with cardiovascular health and health promotion and disease prevention. So it's a really well-written article. One of the recommendations that they make is in regard to something called Life Simple 7. If you Google Life Simple 7 American Heart Association, you'll come right to the page. And there's a ton of information on it. It has wonderful patient education information. But they talk about the 7 it's four health-related behaviors and 3 health-related factors. And really, when we've been talking about the Hypertension Management Initiative, we've encompassed a lot of this already. Non-smoking status, physical activity at goal levels, so walking 30 minutes a day, 30 minutes 3 times a week. BMI less than 25. I checked my BMI, and I'm not less than 25. So I figured I've got a few points to go in order to be adherent to Life Simple 7. Healthy diet consistent with current guidelines, and one of the best diets that we've been promoting is the DASH diet, dietary approaches to stopping hypertension. The health-related factors that they look at are untreated blood pressure less than 120 over 80, and that's untreated. So there is a like a scoring that you can do, and they ask you, what's your blood pressure, and is this treated or not treated? Untreated cholesterol less than 200. I also looked at my own cholesterol in regards to this, and I've got a couple of points to deal with there. And then fasting blood glucose less than 100. So these are, what's nice is it gives you the lifestyle behavior items that we've been quite aware of and work with our participants on. We just completed a qualitative analysis of SASH panels, and one of the quotes that we got out of that was from a SASH participant who shared that she had lost 30 pounds over the last year, and she said it was all due to the activities and the support of the SASH staff. So you can definitely impact weight and help support a healthy behavior with your participants. I also do like these last 3 factors. It really heightens awareness to the blood pressure numbers, which we can easily obtain that information, and then cholesterol and fasting blood glucose. If you don't have access to lab work, which a lot of us do not, you can educate your participant on that and say, if you get information from your physician, such as lab results, and you'd like to review those, that's a great opportunity for you and I to chat. And I have, planted that seed with many of my participants in the past, and they will bring lab work back. And typically, you're looking at cholesterol panels, and you get a fasting blood glucose as well. So good information to be aware of. The other thing that they do is they lay out this system of recommendations for all levels of health care, from the individual to the health system to public health. And one of the areas that we work in is in like a public health type of environment, and I really like these items over here all the way on the right under public health. These are things that we do. We disseminate knowledge of potentially modifiable risk factors for cognitive decline and dementia. So now, you can be also supporting your hypertension work by saying, you're going to be really helping your brain. You're going to be promoting your own brain health through lowering your blood pressure, managing your cholesterol, managing your weight, and exercising, good diet, and all of those things. Provide tools and resources to maintain healthy lifestyles, such as the AHI Healthy for Good program. That's another program that they have online, good patient education material. Provide opportunities for stimulating cognitive, physical, and social activities, and then maintaining a healthy environment, including neighborhoods that promote cognitive and physical activity. This is exactly the essence of SASH. It is what we provide at our panels. It is things like your walking programs, your meditation or relaxation programs, Tai Chi, chair yoga, all of those items fit into this. Even just a coffee hour, that fits into this as well. We don't fund research on risk factors, although we do participate, obviously, in reporting our outcomes. The other pieces that I do like from this are at the individual level, so that can help you understand some information that you could include in somebody's healthy living plan. You could pull up Life Simple 7 at this website and go through it with somebody. Remain physically active, eat a healthy diet. Evidence suggests, they suggest the Mediterranean diet preserves cognitive function better than a low-fat diet. And then addressing vascular factors if present with a primary care practitioner. And I would definitely look at this with your participants and evaluate this against what is going on with their healthy living plan. And you all do this really, really well. This is an example of what my Life Check Life Simple 7 looks like. It is available on www.heart.org, and there is the direct link to it. You'll have this. When you click that link, it asks you a series of questions, and then you get a score, and that score can be printed out or emailed to you, and you have to set up an account. So, it's something that maybe you want to go in and just play with for yourself, so you get educated on it, and then your participant could easily do that with you online as well. And this is some more information about Life Simple 7. Each of the blue, learn how to manage your blood pressure and learn how to control your cholesterol. These are links to patient education material, but these are all of the interventions, manage blood pressure, control cholesterol, reduce blood sugar, get active, eat better, lose weight, stop smoking, and then they have patient education materials that go along with that. So that you'll have a link to the article, and if you have any questions about it, definitely let me know. I think that one thing to think about as you reflect on what you've heard today, and if you read the article further or more in depth, is how can you incorporate those 7 interventions into the practice and the evaluation of how you're working with your participants, especially as you're developing the healthy living plans. Once you've done your assessment, identifying gaps, and then developing the healthy living plan, and then what interventions rather can you take with your participant. That is the end of what I have to present. Does anybody have any questions about the information I just presented to you? It's pretty straightforward. It's the first time I've seen a really nice, succinct article, including everything that we've been including in our hypertension management program and protocol. So I was really thrilled to see something brand new published, and it's all backed up by American Heart Association, American Stroke Association. So any questions that anybody has? Well, if you have questions afterwards, you can always email me or Melissa. Melissa helped me put together the information on the assessments. November, I will send out an email for you. I believe the topic's going to be on depression, and we'll have a guest speaker on a meeting with her next week. So we'll nail down the date and the time, and it will be that's our topic that we're choosing. The one speaker that I did want to have this month, but we'll try and get them rebooked, is for the new opioid prescribing rules, and so look for that. I'm hoping December or January we can get that person in and do that webinar with you all. So with that, I'll give you all 10 minutes back in your day, and happy Friday, TGIF. Have a wonderful weekend. Bye.